Basically, sir, is exploring the peaks of orthopedic excellence. Here, sir, this is a platform which we have created for you all to connect with each other, to share the new thoughts and ideas and the new developing technologies in the field of orthopedics. So, sir, before I begin the session, I'll invite Dr. Bijoy, sir, to please light a lamp and initiate the process. Yes. All of us can Yes, sir. Sir, please.
It just feels that knowledge is not easy to come by. Struggle for
Yes, sir. Thank you, sir.
Thank you, sir. Thank you, thank you, sir.
Thank you very much. Right, sir. So I'll take this opportunity in first of all introducing our chief moderator today, Dr. Bijoy. Though he's such a tall personality, doesn't need any introduction, but it's my duty to at least formally introduce to you. You all know him so very well. So Dr. Bijoy sir is a director. He's himself is a pediatric orthopedic and a spine surgeon, and he is a director of pediatric orthopedic in B. Nanavati Super Speciality Hospital, Mumbai. He is the president of the World Body of Orthopedics, CCOT, he was from 20 to 22, and current president of the International Federation of Pediatric Orthopedic Societies. Then he is the chief editor of the Journal of Pediatric Orthopedics from 2006 onwards till date. So it's a real honor. And he's been a past president for Pediatric Orthopedic Society of India, Indian Academy of Cerebral Palsy, Indian Orthopedic Association, Asia Pacific Knee Society, Asia Pacific Pediatric Orthopedic Society, and World Association Against Infection in Orthopedics and Trauma, WAIOT, and many more. Sir is an honorary fellow of the Slovak Orthopedic and Trauma Society. Sir, he has won many awards and has delivered many prestigious lectures all around the world. Sir, he's innovated and introduced many surgical procedures in India. In fact, he's been credited with and published 6 books, has over 50 chapters and numerous original research papers to his credit. Sir is having a special interest in hip and cerebral palsy. I also take this opportunity in introducing our speaker today, another speaker today who is going to talk about the chronic pain management, and sir is Dr. Bijoy. Bijoy sir has trained in managing mental health and stress from Coventry University and supporting and engaging people with autism from the Swinburne University of Technology. He has got certification in infectious disease from London School of Hygiene and Tropical Medicine and sleep deprivation, habit solutions and strategies from the University of Michigan. Sir is received certificate on COVID-19 awareness and management in partnership with Health and Wiki and Science of Medicines from Monash University, Melbourne, Australia. He is also having a certificate of participation awarded from H2H Marketing and Philip Kotler, the brand management guru. And he has been a medical marketing person from Manipal Academy for Higher Education Association with Pharma State Academy. Sir is a director in medical services, a training and medical director of repute of many pharmaceutical companies in India and abroad. He is a visiting lecturer and faculty member of EDI Kolkata. He has more than 30 years of experience in medical science and training and has got innovative formulation development experience. Sir has been involved in clinical trials, conducting CMEs, seminars and focus group meetings has been his passion throughout the time time that he has been associated. Now I invite Dr. Ashok Johri sir to take up the proceedings ahead, and also to introduce our main speaker today, Dr. Aditya Khemka. Sir, please go.
Well, thank you, Dipin. It's been a great privilege to be associated with all of you, and I welcome all the orthopedic surgeons who are here. This actually arose out of a discussion, where we wanted to explore some fringe topics, interdisciplinary topics, and we were thinking, how do we do it? For example, genetics or endocrinology, or other areas where orthopedic surgeons are not so strong. So this was the basic idea, and I'm happy that Inocare took this up, and they have started with this series. So here we all are, and it's a pleasure for me to introduce the young man sitting there, Dr. Aditya Khemka. Well, he is an orthopedic surgeon, obviously, but mahir in the field of arthroscopy, arthroplasty, trauma surgery, and he has a special niche area called osseointegration. So amputees, where we have to join the stump, the bone of the stump to the prosthesis, so that we obviate the stump interface problem. I was also fortunate to meet with his guru, Dr. Al Muderis from Australia, who does a lot of osseointegration work, and he's shown some very fantastic results. I'm sure Aditya, I don't know if you are speaking about it today, but I think we will call you again to speak on this topic, and amputee rehabilitation and surgery and rehabilitation, I think, is a very, very important, different area. Aditya is connected with many hospitals, Hinduja, Khar, Bridge Candy, Bombay Hospital, Saifi Hospital, where his interests in arthroplasty, especially revision arthroplasty of the hip and knee. So that is his area, and of course osseointegration, I think he is a pioneer in this country, and using robotics and navigation, especially for osseointegration, I think he is a pioneer there. So we welcome you, Aditya, and it's so nice to have a young person here speaking to us and giving us knowledge of this subject of artificial intelligence and robotics. Now, when I studied orthopedics, there was nothing like, we didn't even have intelligence. So artificial intelligence was out of question. All that we knew was to pull and put the patient in plaster or give them traction. So from that we have come a very long way, and elderly people like us have now to go down to learn about AI and its application in orthopedics, especially in the fields which are of his interest. I think there are many applications of AI. And robotics also. So robotics has come in a big way in arthroplasty. I'm told the results are better with robotics, especially the precision and the long-term results. There are some early papers to say that the results are better. So we would like to know more about it, and this was one of the topics I had marked out. That is the area we want to know more about it, and I'm happy that Aditya is filling the gap. So Aditya, I invite you. The field is yours.
Thank you so much, sir, for that introduction. Thank you for having me, and thank you all for coming, and people who joined. So I'll give you my 2 cents about artificial intelligence and robotics. So essentially, all of us as individuals have now become very insecure. And that is one thing that we must understand. The insecurity is actually related to the artificial intelligence around us. But we must realize that this artificial intelligence shouldn't make us insecure, but should make us better surgeons. But being a member of the fraternity, I am very, very strong about our core doctor group. We must overcome the pharmacological or the industry influence that is being taken over in artificial intelligence. And my main aim of the talk today is to give you a few things of what I think about artificial intelligence, but how we can incorporate it in our lives in order to make it better. So I actually thank Dr. Johri when they came up with this topic. I found it very interesting, and then we did some work in order to find, because this has become a part of what I do on a daily basis. So I have no disclosures for today's talk. So the whole idea of why all this is happening is because we started off here, we improvised, but now we've come back here. So this computer, I used to utilize this slide to say people have hip and knee problems, but now I'll say we have problems with artificial intelligence. So again, artificial intelligence is essentially human intelligence extrapolated. Or kuch nahi hai. It's essentially they are learning from us, but we should not be giving into them. That's the only thing that we need to understand. So there have been large number of papers. This was one paper that I picked up from E4. It was a very nice paper. Actually tells us whether we are actually having false hope. It shouldn't be like waiting for the Rajma Chawal of mummy after coming back from hostel. It doesn't work like that. It essentially should make what you're doing on a daily basis slightly better. So, what is artificial intelligence? So I'm not going to give you bookish definitions. I'm just going to say it is a simple ability of a machine to interpret the data that we feed in. This is very important for us to understand. So there is another effort which has recently come in Arthroplasty, and it has come from the ISH society. And that society has been to make the first ever Indian registry for Arthroplasty. I think that is the start, so that we can actually determine and take steps up of how well we all are doing as surgeons. So it is essentially interpreting external data. जो पहले Excel में we used to keep telling our juniors and fellows to keep. So this is something which I would propagate, that I still maintain a logbook, I still maintain height, BMI, X, Y, Z of all my patients on my own on a daily basis, and I try to do it right after the case. So you have an Excel sheet in front of you and you do it then and there. If you have a format, it literally takes you 30 seconds, and then this will give the machine the ability to interpret my own data. So there was, where did it all start? Right? And evidently in orthopedics starts in Germany somehow. So this is actually a picture from Imitation Game. This started off with the German Enigma, when nobody could predict after during the First World War as to what Hitler's movement was going to be. But just what he did was he took inputs, जो खबरी input होता है, he took that, he put it in the machine, and the machine spat out what Hitler was going to do next. And that is the only way that they could defeat. See, the bullet was shot by the German army, but where Hitler was going to be was told by the machine. So that is very important for us to understand. The artificial intelligence is here to help and not take over. So everybody has done this. Everybody has played chess on Microsoft. You know, the old versions of Microsoft. This is the most basic form of artificial intelligence. A computer is playing against you. Why? Because all the moves have been fed into it. Yet there is a chance that you can defeat the computer, not because Microsoft is lap-sided, but that's what really happens. So that was when solitaire and chess, and that's how we started accepting this in our data. Then iPhone came up, right? So this is from my iPhone. I said to Siri, call my dad, and this is what exactly she did. Then I said to her, will you be my girlfriend? And she said, I'm not sure who that is. What's your girlfriend's name? So it's a very simple example, but what this tells you is Siri is also learning with you. And यही चीज 4 years ago, I would have asked, where is my girlfriend? Siri would have said, no, I'm not sure if I can do that. So this tells us that the machine is learning. Now, Apple guys have not done anything. This is just an automated software. That is very important for us to understand, that they learn as more and more data we feed in. The lab side of this is Apple is capturing everything you're doing. But then that is something which we have to realize, that we have to spend time away from our phones. So what are the applications of AI in healthcare? Now, my main idea of AI and where AI fits into my mind is medical diagnosis. Because I genuinely feel we are multiple practitioners sitting in this room. If a patient comes to us, all of us will look at it very differently. But AI may give us the ability to look at it uniformly, right? So there was AO manual. AO manual told us this fracture is classified as A, B, C. How many of us actually utilize that in today's day and age? But as a resident, we always opened the book of Ortho and we actually saw where it is classified and what surgery we should do. So with the ability of having a computer telling us that the patient has this fracture, predictability of this surgery will be the maximum and that's the best outcome, it will give the patient the confidence, plus it will give the physician the confidence. So the art of medical diagnosis is very important. I'm not going to stress on drug development and other things because that is a pharma driven thing. The other thing is the AI assisted surgery. So where does this help? Now, there was one concept where this says the robot will minimize the human error, right? But then there is another concept where companies which make implants say that our implants are good enough to allow little above the Gaussian curve, little below the Gaussian curve. Then why worry about the error? So what is AI doing? AI is only helping you. But then you go back to 1950. A person flying an aeroplane in 1950 had to land the aeroplane themselves. Now what happens? All they have to do is press a button and they just have to sit there. The aeroplane lands itself. So AI is already helping everybody in our daily routine lives. So let us accept AI not to minimize human error, but to get uniform results and better results. So uniform is rather better word rather than better results, but uniform results is what I mean, and predictable results. So say if Sir was to do it, or if Dr. Mahale was to do it, or if I was to do it, all of us should reproduce with the same result rather than us being different. That's where AI will help us. So this is the lab side of this, the economy. This is going to become a $40 billion industry. So it's obviously going to benefit a large number of people. So we have to understand that we should utilize it up to a certain extent and not just fall into the trap of the monetary side of things. So is it actually useful to a physician? Does it actually predict clinical scenarios? And whether the decisions taken through AI will actually benefit the patient. I mean, so Sir did mention that there were initial studies which were classified as better outcomes with robot, and I'll touch base on that when I talk about the robotic knee, and that is something for all of us to ponder really. So this is a place, and this slide is very important for me because I have put this slide only and only to showcase very importantly that we need to get predictability in diagnosis. Random X-rays, all of them have fractures, all of us will see it and all of us will treat it either with A, B or C. The idea is to feed this data into a computer. The computer will not only tabulate this data, the computer will tabulate what each of us have done, and computer will tabulate the follow-up results. So what I want is this scenario. That means if the patient has come to the ER, patient is seen by the physician assistant, patient has had an X-ray, the computer has spat out, instability is just a word, computer has spat out what I wanted to spit out, in the sense, this is the classification, this is the fracture, this is how one should treat it. So it gives you exactly this word, that is better risk stratification. And that is what all of us need to understand. It is not there to overcome this guy. It is there to guide this guy as to what to do. So that is extremely important. So coming down to that, first point of AI, or how we should support AI, is data entry. So that is how we should start with AI. And then it actually can predict the outcome. So this helps the patient. So the commonest question we get asked by the patient whom we do surgery today is, sir, how well will I do? Or how much better will I become? Or how, can I go back to normal? With this, you obviously will tell your thing, and that's how the patient will trust you. But with a theoretical answer, or with the computer spitting out an answer, the patient will be very, very confident of your ability and what you are getting into. So वो जो doubt है, वो निकल जाएगा. And that is the difference between Indian healthcare and Western healthcare. So when I am sitting behind an emergency room table in the UK, a patient comes to me and thinks that I am God. I operate and the patient goes away, irrespective of how I have done. In India, healthcare is not like that. In India, patient will come, sir, 5 patients, 5 के बाद में, then there will be a financial implication, there will be 100 other implications, there will be a relative implication. So this minimizes that. This gets us all on a same playing field. So this is very, very important for us to understand. Now, obviously, it helps us in joint reconstruction. Arthroplasty has been the earliest to adopt most technologies. Arthroplasty came in the early 2000s when they started saying let's adopt computer navigation. Then the computer navigation was upgraded to ligamentous balancing. Then they adopted navigation of the cup placements. So this technology to be adapted by arthroplasty surgeons was very, very easy really. And that's how pharma companies came up. A large amount of orthopedic oncology. So this is again very important as to how these tumors will spread. So again, it goes back to diagnosis and predictability as to where is this tumor going to go. For condyle, what I would do today would be a GMR, a distal femoral resection. If it's a 25-year-old patient, I'm actually predicting that the patient is going to have 4 surgeries in their life. If the patient does not have any complications. So this will help us to decide, okay, I can treat this patient with chemo. I can treat this patient with radiation. XY. I'm not saying a particular thing has to be this way, but it gives us the options, which we would not have if we were reading out of a textbook. And then sports medicine. So this is another thing. Now everybody will say, where will AI help sports medicine? So in my practice, I get a lot of patients who have partial AC. Young kids, 20, 30-year-olds, they're very scared of surgery. Now I'll say, मैं दूरबीन से surgery करता हूँ, I take the best graft and whatever. But you want an outcome. You have a clinic in Thailand. Now what they do is they inject stem cells in this graft. But as a surgeon sitting in Bombay, I have no idea about this. If we are all on the same platform, what it will help us to do, it will tell me if so many fibers are torn, if I use that technology, this is your result. If you use the technology, this will be your result. So that becomes very, very important for us to understand. So sports medicine, very, very important. Now, for example, I had a member of parliament come into my clinic today. 50-year-old gentleman, gone to the who's who of orthopedics in Bombay. Somebody has told him surgery, somebody has told him no surgery. And I sat with him for 5 minutes, I heard his story. And then I said, sir, you're 50. I'm not looking at doing arthroplasty for you today. So what are my options? So I said, first thing, you haven't been diagnosed. You just have a plain, simple 2D X-ray. What does a 2D X-ray tell me about you at all? First thing you need to do is do an MRI. At least it gives me an objective analysis of what is happening. But the sad part is that he has gone to 10 orthopedic surgeons before me who have not told him MRI. So the funny part is not whether you have offered him surgery or you have not offered it. At least diagnose. So this is where AI would really help in predictability. Now, the most advanced robotic replacement, ignore the brand, but is it a myth or is it actually a fact? So consider me, I passed out 2011. I passed out, became an orthopedic surgeon. I went into the real world, and I didn't know anything. I didn't know anything. I was a houseman in Bandarbawa, and first day I had a bad open compound fracture come into the cavity, and for 10 minutes I was thinking what I'm going to do next. And I have a degree behind me, right? I have an MS degree behind me, but it's not so easy. So if this machine was available at that time, this would have been the best thing in the world. So what I'm trying to come to is a point that young surgeons, this is a beautiful tool. Why? Because it guides you, and it guides you for better accuracy. I'm not saying a senior surgeon is highly precise or highly accurate, but a senior surgeon is more predictable. So for a young surgeon, yes, it's a factor. But for somebody who's very accomplished, it may be a myth. Again, should we sell it? No. So what is the difference between a university hospital and a private hospital in Bombay? In private hospital in Bombay and a university hospital in abroad. A university hospital does what it has to do. It has its clientele coming in from the nearby radius of whatever 100 miles. They just have to go there, whether there is a robot, whether there is no robot. Why can't we have a situation here like that? But that doesn't. That is something which is very difficult within the Indian healthcare system. So I will tell you what do we achieve in a knee replacement, right? So this is something I wanted to point. First of all, correct indication. Now that has nothing to do with artificial technology, but we are all losing it. There are knee replacements being done randomly. 45-year-olds getting knee replacements, 48-year-olds getting knee replacements. It's not the way to do it. And this has nothing to do with AI. Let us get our facts right. Let's choose the right patient first. Once we've chosen the right patient, then there is a surgical approach. We were just discussing some surgeon does one particular approach, some surgeon does others. Let me say one thing. Approaches have been described because they are all good. Why is one better than the other? Because a surgeon doing it is well versed with that approach. तो अपने हाथ में जो काम आता है वो करो. If sir does one approach, I do the third approach. That doesn't mean that I am better than him or he is better than me. The point is that I am good at the approach that I do. And this has nothing to do with AI. And I still have to do it if the robot is still doing the knee replacement. The next thing is accurate bony cuts and alignments. So this is a very, very important point, right? Every robot company will come and tell you that we give you precision. Okay, let's look at your same implant you used to provide us a jig. What was the error in that jig? You go back to the books and the same engineers will tell you that the error in that jig was 0.03 to 0.2%. So essentially what the robot is minimizing is that 0.2% error. Let's assume 0.2% error. So now the question comes whether this 0.2% error really affects outcome. So that is something to ponder. I can't influence you by a biased decision whether I will use it or not is based on availability. And it's based where the error will be more. For example, I did a 120 kg gentleman today for a bilateral total knee. Initially my plan to do was a unicorn total knee because there was only anterior medial osteoarthritis. But I always have a backup of a total knee. I opened the knee, small incision, to do a uni. And then I saw that there was massive patellofemoral arthritis. There were ACL damage. If I would have done a uni, it would have failed in 2-3 years. So then I ended up extending it and did a complete total knee for this particular patient. So here AI would help me deciding preoperatively, giving patients realistic possibilities ahead. Secondly, within the minimal invasive incision that I made for the uni, AI possibly would help me doing bony cuts. A slightly bigger incision, it would help me doing bony cuts. So for that particular patient or today's particular patient, a robot becomes a very, very good tool. So again, we go back to the correct indication. I would put it as correct patient selection. And if we choose the patient correctly, we can actually use the AI to our advantage. Because the cost that it is bringing up now, on an average, is 80,000 rupees to 1 lakh. How many of us can afford healthcare? Forget an extra 80,000 to 1 lakh. Acha, how much is the surgeon making out of it? Nothing. How much is the company making out of it? You can imagine. How much is the hospital making out of it? You can imagine. So there are large amount of implications here. Now, let's compare. So, sir, this is what I was talking about. So, I've got a Cochrane reviews, multiple reviews. So, these actually compared long term, there is no difference between robot or no robot. Yes, what a robot will help us do, it will minimize the soft tissue injury. It will get us less bony cuts by balancing the ligament. So, obviously, the pain threshold will be much lower. But that is the same for an experienced surgeon. An experienced surgeon will not go cut bony blocks, will actually cut minimal resection, and in fact I did fellowships under reputed people, and one of them actually taught me what not to do rather than what to do. And that what not to do essentially helps what the final pain outcome really is. So that is part of what AI. So do you actually really need AI for that? So long-term results are the same as convention. Is it a marketing gimmick, or rather, again, we were talking about it, or is it FOMO? Fear of missing out. A lot of it is happening where it is a fear of missing out, and we should not let that dictate our lives.
Just one comment before you. The American Academy recently came out with a paper saying that they are expressing gross concerns about robotic replacements being propagated for the junior trainees. Because the people who don't learn the mechanical alignment properly, because knee replacement is an art. It is a soft tissue balancing, gap balancing versus your this thing convention.
Yes, sir.
So mechanical alignment. Even John Insall in his paper mentioned the same. So they are concerned that if the new trainees are trained in the robotic way, they may not know the conventional way how to do a knee replacement.
Absolutely.
So they should not be industry driven or market driven with the companies.
Absolutely.
So it's a very interesting article. Because the long-term data it is not.
So the kinematics, sir, you're absolutely correct. I mean, we are exploring bony landmarks only to get the accuracy in a manual knee replacement. We are not, it's not the surgeon's preference. I mean, I am not thinking out of the box that I want to put this way. It has to be bony landmarks. And if I'm using bony landmarks, the error rate in bony landmarks, it all comes down to that. So if a trainee learns the difficult way, adopting newer technology will become easier. So that is absolutely the point. And if you ask me, I am a robot user, so I use robots in a couple of hospitals. But I use it because it's available. I'm not against it, but I don't think it adds too much to my practice. So this is the other thing. Losing out on one patient is okay. I think that's what we all need to understand in our practice. The guy who comes and says, "Mujhe robot hi chahiye." It's okay if you don't do it. You should not fall into that trap. So I completely agree with that. So in the near future, the surgeon's role will be like that pilot, which assists only in landing and takeoff. No, we don't want that situation to arise. So yes, let it come into the fore. Let artificial intelligence take over our lives, and let it do what it's doing, but let it not control us completely. So trust the surgeon. Leave it to me. Sit back and relax. I think that should be the approach. Thank you so much.
So that was a sort of a very nice instructional lecture on artificial intelligence and robotics. As we see it, just to summarize what Aditya said, diagnosis, and especially the radiologists are more concerned with artificial intelligence, because the algorithms based on thousands of X-rays the computer can make, and use that for diagnosis. And also prognosticating, I think AI is an excellent tool to prognosticate based on the outcome studies. And for the surgery, actually, robots has come in, they complement each other. I would open the house for questions, and if any of you have any questions, I think feel free to ask. We can have a discussion.
See, particularly in case of AI, The major problem is that if you'd like to get the output, then you have to give the proper prompt. If your prompt is not up to the mark, then your AI will give you, he will misguide you. You will not get the proper outcome from it. So prompt is one of the factors we have to learn, that what exactly I am telling to this AI and what output I will get out of that.
Absolutely. Sir, I agree. Sir, I was one of the first computer navigation users. I bought an Orthopaedic Bijoy, which I started using in India in 2018. And it was a wonderful machine. It gave me an output after I recorded all the points, but it gave me options. So we are talking about human error shifting from manual jigs to robots, but we are not talking about the human error where I played with the numbers. And it gave me so much time to play and so much ability to play that I really don't know whether it was the output of the machine or it was my output. So I think what you're saying is absolutely correct. So coming back to Malesar's point that young surgeons, if they get absolutely influenced by what the machine is giving out, we can actually go very wrong.
Not only that, see, and one more thing, the robotic TKRs came into picture why? Because initially, see how the hip replacement, you put any hip, if you put it the right way, the patients are happy. You put a Adler hip, you put a Charley hip, you put any hip. If you have done it the right way, it's the best operation on the Same thing doesn't happen with a knee. So what happens is, it's not a forgotten knee. The concept of 20% of the people landing with residual knee pain, which nobody knows, whether it is kinematics or what. So now the technology went from kinematic alignment to patient-specific instrumentation. When I was in Bangalore, we were doing that. MRI scans and PSI instrumentation, but no difference in the outcome. Then came the navigation surgery, no difference in the outcome. So now the robotic surgery. So of course Dr. Ranawat also said that if it is going to last, if the technology is going to be bound to last. So we soon have an answer maybe 10-15 years.
Sir,
But thing is, it is too market driven.
Sir, I attended a master's class with Dr. Guruva Reddy. Dr. Guruva Reddy's hospital is a huge hospital in India. It has 7 robots. And the first line with Dr. Guruva Reddy says, it has indication only for uni and more than 150 kilo patient. So he doesn't have a bias. He has all the companies with him. But it is coming out from an orthopedic surgeon who is experienced with a large amount of AI.
Same thing happened with Dr. Agarwal also. He is still not working.
But AI, I think, could be of use. We recently did a study with ChatGPT for engineering hip problem. And as he said, you give the proper prompts. We had 8 questions, 8 clinical scenarios. And I'll tell you that as experts, we're completely satisfied with 5 answers. 5 answers which were given by the
ChatGPT.
Absolutely. Yeah, ChatGPT.
Yeah, absolutely. In fact, it gave more than what we would have told our patients. It's really very systematic.
That's a guiding tool.
So I think that could be of use to us, especially management like plaster care or rehabilitation if you have done a surgery. It's very protocolized. I may, as the orthopedic surgeon, miss out telling the patient certain pointers, but ChatGPT gives you instead everything. So there are protocols.
In case of your ChatGPT, you have a plugin and other tools that will give you
Because we were very impressed. It was very easy. The answers which were given were as if some experienced senior pediatric orthopedic surgeon sitting there.
Does AI will take the socio-economic factors as well, as far as an Indian scenario is concerned? Because it will affect a lot, because they are so very socio-economic strategy in this country and society.
I think we are making a mistake. We are making a mistake. You know, the amount of infrastructure that goes into maintaining a government hospital, the amount of money which goes in, it's enormous. We cannot even imagine. एक AI का computer level में कितना पैसा लगेगा? The thought process is wrong. We are looking at it that people are selling 10 crore robots. That is why it is expensive. No. For what we are talking about is cohesing our data, and that requires a computer.
And for that, you require more of all the socio-economic factor to be considered when we put the data in the AI. That is very, very important. Because if the patient is having the good money if we go for the robotic and AI and all as well. But he want to sit the next day the cross leg in the on the ground. So means that kind of data we have to feed in the AI in this kind of a social.
So that is a good point. All this clinical outcome data, none of the papers will say patient can sit cross-legged.
Yes.
Because
That's the
patient is
problem.
sitting cross-legged because of the implant and not because of the way the surgery is done.
Absolutely. And the patient to let the patient know and understand this thing. Patient has to know the concept of AI and robotic first, how why he is going for that.
But now they are going because their friend has done robotic.
Definitely. Because they have the highest expectations now. Okay, the surgeons do the surgery and now robotic is doing. So I will get a better result, I will get better move, I will become now the Olympic athletes, even if I am the 60. Because they got more expectations now. Because they are paying you more for that one. So that kind of understanding and awareness and
So that is what we need to change. That is what I was
that
talking
is
about
fine.
monetary benefits.
Yes, absolutely.
In India, everything is equated to money.
Yeah.
If somebody charges 1500 rupees as OPD fee and somebody charges 500, the 1500 doctor is better. It is wrong.
Just one remark, about this robotics and AI, what is the legal angle to it?
Sir,
What is happening abroad? Because India is just introduced.
in India, it is still indemnity of the surgeon.
Yeah.
It is, and in fact, the hospitals are signing disclaimers with the surgeons. So I have signed a disclaimer yesterday with one reputed hospital, where if the robot makes a mistake or if a complications happen to a patient, it is my indemnity. It is not even the hospital indemnity.
Absolutely.
But abroad, what is happening is because universities are buying these, they indemnify. The universities are the ones which are indemnifying the complications.
Yeah, but abroad they are not implementing in all the sectors. Like UK, all the DJs are still doing standard DJs. They will not implement it till actually the verdict is out.
So because the patient's expectations have gone up, and medical legally, I think,
Indemnity
if they're
should
not
also
satisfied.
should also include the robotic point of view, because the patient is asking for the
No,
robot.
and the worst case scenario, the robot owners are talking anything.
Yeah.
I had a patient who said she'll have a painless TKR, smallest incision, and she'll be up and about on the next day.
Yeah.
Now, painless TKR a robot cannot do, but then that is the expectation.
So much information is being meted out.
It's all misinterpreted.
Now, within the span of 2 kilometers, one guy will say I have Gen 1, the other guy will say I have Generation 2,
Yes,
third
yes.
guy will say I have Korean, fourth guy will say I have Johnson & Johnson. So it doesn't work.
And that's what the problem will be. The feeding to the AI also will be the greatest problem in India, I think, because as you are telling me, different surgeons within the 1 kilometer distance they are sitting and they are offering different options for the same diagnosed need. Still they are giving a different option.
But my solution to this is very simple.
Yeah.
Sit with the patient, explain to the patient. If the patient trusts you, do the surgery. Otherwise,
Yeah, there is a basic concept we are going on already. But when you're thinking of AI,
I think India is so heterogeneous everywhere,
Yeah.
so it will be difficult.
very difficult to get the data to AI.
True, but whatever benefit we can get from AI, I think we should take it.
We should take it.
that is very important.
Absolutely.
Sir, you were asking something.
So you told that you did unicondylar replacement and you were not aware that on the table you will require a complete knee joint replacement. When there is MRI scan specific to find out. Then did you miss that MRI scan?
No. So the MRI again, see you have to understand the cost constraint. So it is my mistake. I don't endorse MRI scans. So the patient went to a particular center, got an MRI scan. The MRI scan was one test. It came back saying that there is mucoid degeneration of the ACL, but when I opened it, the ACL was completely torn. Now, whether I go back and blame the MRI center or not, I have a situation on table where the ACL is torn, so I have to decide whether I want to convert to a total knee or a unicondylar.
Absolutely.
I decided it that way. Now, yes, if you go back and see my error could have been that I could have sent him to a better MRI center, better reporting person. But that's a problem, practical problem we all face. So what happens is a lot of patients come to me through different physicians, and they endorse a certain center. They will want it done only at that center, but the reporting of that center will be very, very poor. You have to deal with it. You have to rely on what I am seeing on an MRI scan.
I did my knee fellowship in York. So there they were not doing MRI routinely. Anthony Gibbon does around 100 partial unis a year. So he just says 2-finger test of Gibbon. So if the patient points pain here and the X-ray is showing, he'll plan a uni. If the patient says this, he's never going to do a uni.
Yes, absolutely right.
And not
So
only
basic
that,
medical, yeah.
when he's actually doing the TKR, he's fully backed up with a total. Uni is backed up with a TKR.
Which is normal.
The moment you take a medial parapatella, you look at the patella, if it's sworn out, he'll change plan immediately. It's an on-table decision.
That's
But a clinical decision will usually match it because it's so accurate that the moment it is here, he's happy to do a medial.
So, this is two things to it, right? There is something called level 6 evidence, which is expert's opinion. We are all expert opinions, right? There are two sides to it. Either be very confident and egoistic about it, or either rely on it. So that's the whole thing. But everybody plays by what they have experienced. At the end of the day, if a patient goes under my care, I want the best for the patient. So I will go by my thought process, which may differ with another side. So the whole idea of AI will be to make us on level playing field. That मतलब ये clinical test भी नहीं होगा, मेरे को MRI का problem भी नहीं होगा, third person who's doing a 3 Tesla MRI will also not have a problem. We'll already have an answer. Because this guy is this, will do this.
All ideal conditions basically from all ये.
होता नहीं.
So this is बहुत मुश्किल है.
Thanks, Aditya. Brilliant.
Thank you, sir.
Thank you very much for coming. Invite Dr. Bijoy. We are eagerly waiting for your talk today on chronic pain management. It's a little different from our routine levels.
Welcome to everybody. Now we have heard about this AI, and but you don't think so that AI, if it is being implemented, then surgery is not required. Robot will be able to do everything. That will not be possible. And see, AI will help you a lot to take the decisions. Now we are coming in a different subject, that is the new advancement in chronic pain management. Particularly if you see that chronic pain management is always, it is underestimated. Now we would like to see the first, that what are the painkillers or maybe which takes care of your inflammations and pain, and what are the drugs are available right at the moment. The first one is that all of us know the opioids. Opioids, particularly it acts on the mu receptors, and we have also got the opioids that is doesn't have the opioid-like side effects, but the efficacy is as good as your opioids or like your tapentadol or tramadol. Now coming to the NSAIDs, when we are coming from NSAIDs, now we have two options. One is selective COX-2 inhibitor, one is non-selective COX-2 inhibitor. Now here is one problem, that non-selective COX-2 inhibitor, the major problem, all of us know that there is a GI irritations, then you will find a nephrotoxicity. Also there is a problem of coagulation of blood. Now we are coming to this, your selective COX-2 inhibitor. There is a major problem. Most of the selective COX-2 inhibitor, it has been withdrawn from the market. If you see the rofecoxib, it has been withdrawn from the market. Valdecoxib, it has been withdrawn from the market. Why? Because it is a selective COX-2 inhibitor. There will be no GI irritations. But the major problem is that there will be acute atrial prolongations, the cardiac arrhythmia, and it has been found. Right at the moment in India, only two selective COX-2 inhibitor is available. One is etocoxib. Still it is under scanner. Anytime it can be withdrawn from the market. And recently, another selective COX-2 inhibitor, it has been launched in India, but in abroad, already it has been withdrawn, but here it has been launched. That is palmacoxib. Okay. Now, so there is a disadvantage of selective COX-2 inhibitor. Now, coming to the antidepressant. Yes, in case of orthopedic neurological disorder, this antidepressant we are using a lot. The first one is that antidepressant, particularly tricyclic antidepressant drug, nortriptyline, it is being used in our day-to-day practice. Second one is that
SSRI, second one is SNRI. But if you see that serotonin norepinephrine reuptake inhibitor is better than your SSRI, it has been found. And we are coming to the anti-epileptic drugs. The major two anti-epileptic drugs are being used in our day-to-day practice. One is pregabalin and second one is gabapentin. Levothyroxine we are not using to that extent, particularly in Indian context, but abroad it is being used a lot. Now, other things if we take into consideration that local anesthetic and your paracetamol and nifopin, these are being used. But there is a major changes in particularly one aspect, that is in case of cannabinoids. We know that cannabinoids give very good pain relief, but we are not in a position to use cannabinoids because the source is cannabis. When we extract from cannabis, major problem is that it has an effect on CB1 receptor in the endocannabinoid system. And because of that, there will be a psychoactive effect. Maybe the pain relief will be excellent, but because of the psychoactive effect, we are not in a position to choose this particular product. Now, today we'll discuss, there is a options. Now we have got the source of non-cannabis, from where we can extract this BCP, the beta caryophyllene, which is the principal active ingredients. So local anesthetic, when we are using particularly 5% lignocaine we are using, it basically edits the nerve ending and does not allow the pain stimuli to reach your CNS. And basically it is being used in case of your post-operatic herpetic neuralgia as well as diabetic neuropathy. Now coming to the non-steroidal anti-inflammatory drugs. If we see the non-steroidal anti-inflammatory drugs, we have two different pathways. One is cyclooxygenase, another one is lipoxygenase pathway. If we take into consideration this cyclooxygenase pathway, this COX-1 it is found within our body. This particularly helps in formation of good prostaglandin, which takes care of our physiological function. But this COX-2 is not found within our body. When there is an injury and trauma or infection, this COX-2 is produced. Now here non-selective COX-2 inhibitor, they blocks your COX-2 and COX-1. Because of inhibition of COX-1, there will be no formation of PGI2, which basically helps in formation of mucosal lining. Second one is that there will be no formation of PGE2. Automatically my renal function will be disturbed. There will be no formation of TXA2. That there will be a problem of coagulation up there. Another pathway is the lipoxygenase pathway, where we'll find that there is a formation of leukotrienes. Basically, it is also responsible for pain and inflammations. Now coming to the anticonvulsant. Then we are coming to the anticonvulsant. You will find that we have a pregabalin and gabapentin. Now if you see that its action is particularly in alpha-2 delta site, where we can see over here, this one, this is a calcium channel at the presynaptic nerve ending. Here, it's just attached with this particular site, and there will be no entry of your calcium ion in the presynaptic nerve ending. And if there is no entry of calcium ion in the presynaptic nerve ending, then there will be no release of glutamate and substance B. The glutamate basically activates your NMDA receptor at the postsynaptic nerve ending, and that leads to your pain. Now here I would like to tell you, just going back over here, then what is the role of your pregabalin or gabapentin? It binds with this alpha-2 delta subunit. Once it binds with that, there will be no entry of your calcium ion in the presynaptic nerve ending. So the release of your glutamate will be stopped, and there will be no activation of NMDA receptor. Now opioid derivatives, we know that it basically acts on your mu receptors, and when it activates your mu receptor, so there will be no pain sensation. Now this is the most important part we have to take into consideration for the pain management, that is monoamide reuptake inhibitor. Now there are three, already I have told. One is tricyclic antidepressant drug. Now tricyclic antidepressant drug, nortriptyline, is being used a lot. And nortriptyline has a multiple function for taking care of your pain. Number one is that it blocks your calcium channel. It also blocks sodium channel. So there will be no entry of sodium ion and calcium ion in the presynaptic nerve. When there is no entry of calcium and sodium, there will be no release of your glutamate. Second one is that there is a serotonin release from the presynaptic nerve ending. If I would like to get relief from pain, then I have to increase the concentration of serotonin and norepinephrine in the presynaptic gap. Now what happens that serotonin, which is released from your presynaptic nerve ending, it will be taken up. There will be a reuptake once again in the presynaptic nerve ending. Now here, the major plus point of your nortriptyline, it blocks your serotonin reuptake and increases the concentration of serotonin in the synaptic gap, and it takes care of your pain. Not only that, nortriptyline directly block this NMDA receptor. So whatever glutamate it has been released, it will not be able to stimulate your NMDA receptor. So the complete pain will be taken care of. So that's why nowadays you will find that use of nortriptyline, it has been increased. And it is better than your amitriptyline because your dryness of mouth and your cholinergic effect you will not find to that extent. Now here if you see the schematic things, then it will be clear. See, there is an entry of calcium ion, there is an entry of sodium ion, there is a release of your glutamate, and this glutamate activates your NMDA receptor and that causes your pain. And you will find that there is a release of serotonin, but it is being reuptake by presynaptic nerve ending. And this is the pain signal. Now you see that the action of your nortriptyline. The first one is that nortriptyline blocks this calcium channel. There will be no entry of calcium ion. It blocks your sodium channel. There will be no entry of sodium ion. So there will be no release of your glutamate. Second one is that it also blocks this reuptake of serotonin. There is no reuptake of serotonin, so more serotonin will be at the synaptic gap, so it will give the pain relief. And second one is that directly it also blocks your NMDA receptor. So whatever glutamate it has been released, that will not be able to activate this NMDA receptor, and the pain will be controlled completely. Now, this is more or less the drugs which are available in the market. Now there is a lot of new modalities of drug administration. We have changed in the drug delivery system. Now drug delivery system, when we have changed, actually the older drugs, we have changed the drug delivery system. By doing so, we have got two benefits. One is that we can reduce the dose of this particular drug and we can overcome the side effects of the drug. Such things, the first one is that patient control analgesia, that is PCA for opioids. Now here patient himself can regulate this, your opioid drugs. And that will give better satisfaction and better pain management. Though it is not being used over here to that extent, but in abroad it is being used. Transdermal administration of opioids, particularly in case of fentanyl, it has been adopted because it's your lipophilic opioids. And if you take into consideration these things, it is being used in case of your chronic pain, particularly your cancer pain. Now it is also being used other pain management. But it cannot be used particularly for post-operative cases. Why? Because if you see that fentanyl, when it has been applied on the skin, obtain the maximum therapeutic concentration, it takes 12 to 32 hours. So the pain relief will not be there to that extent. So in case of chronic pain, it will be really good enough. Now coming to the intranasal spray for opioids. Here also we have got a very good options. Fentanyl, there is one major problem is that it undergoes fast metabolism. Now, When a drug undergoes fast metabolism, always it is not bad. Sometimes it's good, sometimes it's bad. I can give you an example. When we take the aceclofenac, after taking aceclofenac, it absorbs in the from intestine, it goes to your liver. Partly it is converted into 4-hydroxyaceclofenac. 4-hydroxyaceclofenac and aceclofenac both give the same therapeutic benefit. So I don't have any problem. Now sometimes we take an inactive form of drugs which converts into active form. Take an example that in case of your paracetamol, the inactive form is phenacetin. When phenacetin it has been given, after absorption it goes to your liver, it is further converted into your paracetamol. So I am getting a better therapeutic effect. But if I take into consideration metoprolol, antihypertensive drug, when I have taken after absorption, then it goes to your liver, partly it is converted into inactive substance. So whenever we use metoprolol as an antihypertensive drug, we have to give in a very high dose. Now there is another plus point is that it is effectiveness and non-invasive. That's why it has been well accepted. And there is also a sublingual spray. But sublingual spray, it has been developed only in case of oxycodone hydrochloride. Acetaminophen that we are using as a IV, nothing to be talked about. Now, in case of NSAIDs, there are certain changes we have found that your ketorolac has been approved as a nasal spray. Here I would like to tell you, recently in India, new NSAIDs has come. And in India, 2 companies have launched this particular NSAIDs, that is zaltoprofen. Zaltoprofen is little bit site-specific COX-2 inhibitor. We cannot say that it's a selective COX-2 inhibitor, but it's a site-specific selective COX-2 inhibitor. So GI irritations and other complications because of inhibition of your COX-1 will be very less. So this is the new development, particularly in case of your NSAID. And other things that we have got the nano. Second one is that what we have done in case of diclofenac, it has been solubilized in beta-cyclodextrin. Beta-cyclodextrin, which is basically an excipient which increases the absorption and the bioavailability. So what happens in case of diclofenac, when I am giving one tablet 3 times daily, instead of that I can give 1 tablet twice daily. So I can minimize the side effects of the drug, but I will get the same benefit. Now this is another your transmucosal immediate release formulation of fentanyl. That is fentanyl citrate, because it has been sprayed inside the buccal cavity, and as because our buccal cavity is vascular in nature, then there is an immediate absorption from here, and it gives a better bioavailability and quicker onset of action. This is another aerosolized liposome encapsulated, that is in fentanyl as well as your morphine. It is not being used here to that extent because it will be give delivery to the periphery of the lungs, and there will be a sustained release of the drug, and also lipid absorption. Because of that, it gives better systemic circulations. Now, recent advancement in the pain treatment. Tramadol, it is not a new thing, but there is a certain changes. It is being used in case of nowadays in case of neuropathic pain, in post-operative neuralgia, and we have also seen tramadol with paracetamol combinations in the market. This is the new anti-epileptic drug. Very few doctors they use this particular limotrazine, but it's good because it blocks your sodium channel. By blocking your sodium channel, it doesn't have any effect on calcium channel, whatever we have found in case of your nortriptyline, and there will be no release of your glutamate, and there will be no activation of NMDA receptor. And it is really good, but I don't know that why in India it has not been picked up to that extent. Side effects also is very minimal. Then we can use a lignocate plaster and topical capsaicin. This topical capsaicin, it has been picked up very recently, and you will find that in case of chronic pain, it is very effective because it does not allow to accumulate your substance P at the nerve ending, as well as it depletes the substance P from the nerve ending. So there will be no stimulation, to nerve ending, and there will be no message goes to your CNS, and the pain will be relieved. So novel targets. Now here I would like to talk about that is the new changes, and particularly in pain management, and we'll find that there is a future in taking care of the pain management, and we can manage the pain effectively. Earlier, we are not in a position to take into consideration that is your cannabinoids, particularly as because it contains THC, also it contains your CBD, that's why there will be a psychoactive effect, though there is a good pain relief. Now we have got the BCP, beta-caryophyllene, but beta-caryophyllene, if it is derived from your cannabis, there will be a psychoactive effect. So the research was going on during that period, that how we can derive this, your BCP, non-cannabis source. Now we have got two non-cannabis sources. One is Piper diagram and second one is clove. Both source can give you the BCP. But major problem with Piper diagram, when we extract, the content is very, very negligible. And if you see, the absorption and bioavailability is not up to the mark. Now if you come to the next one, that is clove, it provides the maximum amount of BCP, and the bioavailability is very high. So the clove has been taken into consideration for the source of BCP, which is absolutely devoid of psychoactive effect. Now the question is that this BCP, which has been derived from your clove, why doesn't have the psychoactive effect? If I see our endocannabinoid system, then there you will find that there is a CB1 receptor and CB2 receptor. CB1 receptor, basically it is found in the CNS, that is in the brain as well as spinal cord. When it will be activated, there will be a psychoactive effect. But this BCP is very selective. It only activates your CB2 receptor in the periphery. So that's why it doesn't have any psychoactive effect, but it will be a very good pain relief. When it activates your CB2 receptor, on the contrary, there will be an inhibition of the pain cascade. What will happen? Two cytokines will not be produced. One is interleukin 6 and TNF-alpha. Second one is that it also reduces the activation of NF-κB, nuclear factor kappa beta. This NF-κB is one of the chemical substance which will produce more your TNF-alpha as well as your interleukin 6. It's absolutely natural and bioavailable and no psychoactive effect. Now, in India, this particular fixed dose combination, it has been launched. BCP, that is your 100 milligram, with curcuminoid, roswellia and combifera. And along with that, there is a MSM, methyl sulfonyl boron and melatonin. If we take into consideration the entire thing, the chronic pain, you see that particularly your instant relief from pain will be with roswellia, curcuminoids, BCP and combifera. Major problem, whatever we have found, that when in case of grade 1 osteoarthritis or the later stage of your grade 1 osteoarthritis, we give the painkiller for symptomatic relief. And we give the Cisar group of drugs separately, that is glucosamine, chondroitin, MSM, University, then we give also collagen supplement, then high hyaluronic acid. So these are the things that we give. Major problem is that most of the cases you will find this Cisar group of drugs will not give immediate effect, because my regeneration of cartilage will not happen within 1 month. And if there is a synovial fluid, it has been exhausted, it will not be developed within 1 month. So what happens in this case? In most of the cases, patient will stop the medications, but they will not get it. But in your preparation, if there is anything which will take care of the pain immediately, and they will continue, and they will get the better effect for other ingredients. So other ingredients, if you take in case of MSM, it helps in formation of your collagen. Also, it lubricates the joint. It inhibits your nerve endings, so that no pain sensation will reach in your brain. Then if you come to this boron, boron has the unique features. Particularly, we have not utilized boron to that extent, particularly for treating your osteoarthritis. What does it do? When there is an activation of nuclear NADH, then when it is activated, there will be a further formation of superoxide anion. Now here, this boron basically, what does it do? It deactivates NADH. So there will be no further formation of your superoxide anion. And this superoxide anion will be also scavenged by boron by increasing SOD, superoxide dismutase, and glutathione, which are the endogenous antioxidants. So it will take care of your oxidative damage of the articular cartilage. And the last one is the melatonin. Now melatonin, it has been found that it has a chondroprotective effect. There is a lot of clinical trial that has been carried out so that melatonin will also take care of your cartilage. So if you take into consideration all those ingredients together, really it gives very good effect, particularly in case of your grade 1, grade 2, and also the initial stage of your grade 3. And the dose is 1 tablet twice daily, and it has to be continued bare minimum 90 days to get rid of it. Now, here another new development has been taken place. That is your Khemka. All of us know that it has a very good analgesic anti-inflammatory effect, and basically it activates your mu receptor. Similar effect of opioids, but your activation is weaker as compared to opioids. Obviously, morphine, methadone, if you take into consideration, less. But it has an added advantage that not only it activates your mu receptor, also it blocks your COX-2. So because of these two, it gives a better pain relief. And now if you come to this kosha, here you will find that it's a complex of choline and orthosalicylic acid. Now this particular substance will increases your bone mineral density. It also improves the osteoblastic activity, reduces your osteoclastic activity. And because of that, there will be less loss of your calcium and phosphate from the bones. There will be a formation of those. Not only that, it also helps in formation of your collagen. So at a glance, if we take into consideration that this particular preparation, that is Cola-Shot C2, you will find these two ingredients. Along with that, there is a high hyaluronic acid, which is a major component of your synovial fluid. So there will be a proper lubrications of the joint, and also there will be a formation of your collagen. So articular cartilage development will be there. So sum total effect, the pain will be relieved, also will take care of the root cause of the disease. So Cola-Shot C2 Plus, this is another product which has come into the market. So concluding remark is that there is a lot of pain drugs for management of pain we have got, but the thing is that still there are newer drugs that are coming, but only opportunity is that after a long time we have got the BCP from non-cannabis sources. Earlier we have tried this beta-caryophyllene as because it has been derived from your cannabis source, that has not been accepted by the medical fraternity because of the psychoactive effect. Now we are getting the BCP which does not have psychoactive effect, and we are getting non-cannabis source. Along with that, we have other ingredients which will take care of your root cause of the disease of osteoarthritis. So I think that this InstaActive 4 will give you a better relief in case of osteoarthritis, even followed by your Cola-Shot C2+. Thank you very much.
What is the maximum duration we can continue Cola-Shot C2? Maximum duration.
Cola-Shot C2, 90 days to minimum you have to give to get the effective result. But even after 90 days, if it has been found that till the patient should continue these things, yes, of course, you can continue with, because it's very safe. Because I have told you the Khemka Mira, it doesn't have any side effects. It reduces your pain, but it doesn't have any action on COX-1, there will be no GI irritation, no nephrotoxicity, no problem in the coagulation of blood. And whatever the side effects we come across in case of opioid derivatives, because you will find respiratory depression, constipation, then habit formation, that also you will not find in case of Comifera. So that way it's very effective and you can continue for a longer period of time based on the situation of the patient.
But it is stop the COX-2 as well, na? So it may derive the side effect of COX-2 inhibition as well.
No, it is there is no.
It blocks the COX-2 as
No,
well.
COX-2. COX-2 basically, when there is a COX-2, it will be activated. There will be a formation of two prostaglandins. One is PGD2 and another one is PGF2 alpha. They are the main culprit for pain and inflammation. So this Comifera that blocks your COX-2. Once the COX-2 is blocked, there will be no formation of PGD2 and PGF2 alpha, so your pain is relieved. But there is no action on your COX-1. If the COX-1 is not inhibited, there will be a proper formation of your PGI2. So gastrointestinal mucosal lining will be intact. There will be a formation of PGE2, which will improve the renal function, and there will be no problem of TXA2 formation. So there will be a proper coagulation.
Any effect on QT interval, as you told me about the aprocoxabenone? They have the side effect on the QT interval.
But in case of Comifera, it is not found that
because it is acting for the COX-2 as well, as you know.
No, it is not acting on COX-1.
Oh, okay.
Okay, it is a selective COX-2 inhibitor. It doesn't have any action on your COX-1. But in case of your selective COX-2 inhibitor, that is COX-8, it has been found that there is a QT interval prolongation. But in case of Comifera Mira, it has not been found.
Other question is
your question is that I have understood. Is a selective COX-2 inhibitor, does it cause any QT interval prolongation? Is there any cardiac anything? The answer is no.
And other question is, do we require to add a collagen after starting the Integrative 4?
Yes. See, I would like to tell you, particularly in case
advanced cases.
I would like to tell you that in case of your osteoarthritis, when you are not going for surgery and other things, prior to that, in grade 1 and grade 2, basically we know that the gap will be reduced. Okay, there will be a friction between these two bones. There will be a damage of the articular cartilage. But I have to see that there should be a chondrocyte. Chondrocyte should be there. If there is no chondrocyte, even also if I give collagen supplement, even if I take into consideration glucosamine, chondroitin, nothing will happen. Okay, chondrocyte, if it is there, what I can do, I can develop the matrix. That means I can develop proteoglycan and collagen. Because the collagen and proteoglycan can be developed by giving the supplement. So I can give the collagen from outside. I can give high hyaluronic acid to lubricate the joint. So I can take care of your stiffness of the joint and flexibility of the joint. I can take care of that. But obviously, when there will be no chondrocyte at the joint, so obviously only surgery is the.
It will have an additive effect if you add the collagen along with that inside before.
Yes. Separately you are talking about.
Yeah, because for the pain relief you started Integrative initially. Then we want to build up with the collagen as well for the chronic pain relief or for the chronic.
Yes, it can be given as a follow-up therapy.
It will have the additive effect, or it will not have so much of effect along with if you give only the collagen.
No, only if you give only undenatured collagen type 2 you are giving. You are not giving any other things. No, because you have to also lubricate the joint. There should be a high hyaluronic acid or sodium hyaluronate, or you can go for mobility. So these are the things you have to take into consideration for lubricates the joint. But one thing that when the gap has been reduced, I don't know, some of the orthopedicians nowadays they don't like this traction. They do not like to give the traction. But in my personal opinion that when the gap will be reduced, traction has to be given. At least we can increase the gap. There should not be damage of the articular, because there is a two school of thought. Some orthopedicians nowadays they don't want that we should go for the.
But for us, only traction is to restrict the patient to the bed only. That's the only reason for us. To restrict the patient.
If we get traction, the next door neighbor will operate the patient.
That's the only reason.
We'll be outside. But one question. There have been studies done abroad where in the early stage of arthritis, these drugs work better. As the arthritis progresses, do you think it really makes a difference? Like if I have a patient with advanced arthritis of the knee, all these combination drugs.
Advanced, I have told you that
So
at your joint.
how do we control the pain? Because see, many of them cannot tolerate the non-steroids. They have renal problems, heart problems, etc. So we try to give some pain patches at the most. So do you think these drugs can also make a difference? Because there are no studies on this.
See now, so there is a lot of studies. I'm telling you, you can use the university, you can use curcuminoids with Broswellia. These combinations is very effective in case of your brain relief. Because university, there is a lot of clinical trials worldwide. Even also, if you see the Broswellia basically the active principle is the broswellic acid. And that also you have to see that broswellic acid, there are 4 different forms. Which particular form is there? If it's the AGBA, then yes, of course. And that also you have to see that how much is there. If it is a 20%, then it will be effective. So a lot of parameters we have to take into consideration when we are going for any prescription. Yes, it works. Suppose you are telling that I am not in a position to give these non-steroidal anti-inflammatory drugs.
So what we were conventionally taught, especially with my training over there also in the UK, you give a steroid injection in the knee that calms the patient down and brings the pain down.
So,
all these drugs, they take long time and the patient lose their practically if you give a steroid, they are traveling on somewhere, they are fine. But obviously then we cannot think of doing a joint replacement.
Yes.
That's a different
Right.
one.
And now I would like to tell you that earlier nutraceutical, only nutraceutical supplement was there. Now it has been completely changed. Now there are 3 categories. One is your food supplement, second one is FSD, food for special dietary use. That means in case of your kidney patient, CKD patient, we are giving the supplement. In case of cancer patient, we are giving the supplement. In case of hepatic patient, we are giving the supplement. These comes under FSDU category. And there is another category, just it has come, which is as good as drug, that is your FSMP, food for special medical purpose. Now you have seen that the approval of PEA, palmitol ethylamine, that is food for special medical purpose. Okay, it is as good as your drug. Even for that PEA, you require a prescription of a doctor. You cannot get just, you go and you cannot buy it.
They are using same thing in cancer patients also.
Yes.
Yes. Very good result. In the
Yes,
clinical
correct.
trial, it has been found that PEA is very effective.
Any of the miscellaneous drugs you mentioned about Nefopam, is it a good drug?
Nefopam, yes. See, I would like to tell you, Nefopam only, it has been launched by only one company in India. Okay. Nefopam, yes, it acts, but in case of mild to moderate case. But if it's a severe, moderate to severe, yes, it is not so effective. Otherwise, you will find a lot of brands in the market. You have not found that.
not talk about Dinesulite.
See, Nicosulite is not being used nowadays to that extent because most of the country it has been banned. And in India also the use of Nicosulite it has gone down. Earlier,
What is the root cause of the pain?
root cause of the
Pain. We are just talking about chronic pain, but what is the root cause of the pain?
there's a lot of factors are responsible for pain. If there is a release of your glutamate from the presynaptic nerve ending, if it activates your
What leads to that? There may be some reason for that.
It is happening because in case of any, suppose if you are an injury or suppose if you have an injury and trauma, automatically your phospholipid will be damaged. The cell membrane, it is made of phospholipid, it will damage. So phospholipid, it converts into arachidonic, and from arachidonic acid, because when you have an injury, then COX-2 will be produced in your body. COX-2 is not found in your body. Then COX-2, it converts your arachidonic acid into PGD2 PGF2 alpha. And this PGD2 PGF2 alpha dilates the blood vessels. When it dilates the blood vessels, there will be a more supply of blood over there. That's why you have a redness. Okay. And when there will be a more rush of blood, there will be a generation of heat. Because in physics you have studied that if kinetic energy converts into heat energy. That's why if you touch this area, you will find the worm. And when your blood vessels are dilated, the permeability is increased. So your blood cells and the plasma move out from the blood vessels, accumulate over there. That's why you have a swelling. Otherwise, why there will be a swelling?
That is
Okay.
more of trauma. What about non-traumatic?
Non-traumatic, I am talking about this presynaptic nerve ending, that there is an entry of your, in case of your diabetic patient, if you take into consideration, if there is a nerve damage, okay, nerve damage means if you take into consideration your neuron, your dendrites, cell body, and your axon. Axon is covered by a myelin sheath. If there is a damage of this myelin sheath, your axon will not get proper nutrients and oxygen. So there will be no proper transmission of nerve impulses. Your nerve conduction velocity will be reduced, and you will suffer from peripheral neuropathy. There will be a numbness, there will be a tingling sensation, you will feel the stabbing pain.
Then the pain goes away after diabetic neuropathy.
Diabetic neuropathy,
Pain goes away.
diabetic neuropathy,
There is
once
damage to the sensation is reduced.
see, now we have another alternative, particularly for that. I am suffering from diabetes. Okay, my blood is very high, always in elevated conditions. But I can delay the neuropathy. How? Because this excess blood glucose, which is in my body, there is a aldose reductase. One enzyme is there in our body. This excess glucose will be converted into sorbitol. And sorbitol is highly toxic to the nerve and damage the nerve. Now we have a apelestin, the drug apelestin, which is a aldose reductase inhibitor. So I'm suffering from neuropathy. I'm not suffering from neuropathy, but my blood sugar is very high. I may suffer from neuropathy because there will be a nerve damage, but I can arrest it. I'm not in a position to control my blood glucose level because I'm taking triple drug, 4 drugs. I'm taking SGLT2 inhibitor, I'm taking DPP4, I'm taking your insulin secretagogues, insulin sensitizer, everything I'm taking. Even doctor has also told that you have to take now insulin. But still my blood sugar level is elevated condition and I will suffer from neuropathy, but I can arrest it. I will give apelestin. Excess glucose cannot be converted into your sorbitol and there will be no nerve damage. Earlier aldose reductase inhibitor was not there in India. It was in abroad. Now we have this particular, we can take care of it.
And what about the pregabalin? Because we used to use gabapentin, then we shifted to pregabalin. Now there will be a lot of drowsiness and nausea and swelling.
See, I would like to
and
tell
again
you.
we are coming to gabapentin.
No.
It's like that.
No, I would like to tell you, if you ask me, this is my personal opinion.
So we are asking your
You can
experience.
take it,
Yeah.
you take it or you
Yeah.
not take it. See, if you ask me gabapentin and pregabalin, the best choice is pregabalin. Why?
Absolutely.
Yes, we are giving in a very reduced dose, 75 mg. But in case of your gabapentin, basically if I would like to get the effective result, I have to start with 900 mg. This is the actual dose. But we don't do that. We start with 300, 600, then 900. Okay. Second one is that your patient compliance is better with the pregabalin if you take into consideration the gabapentin. Okay. Effectivity wise, if you take into consideration, you will not find much difference. It varies from patient to patient, but more or less the same effect you will get. But your septic profile wise, if you ask me, pregabalin my first choice. Now pregabalin also it is available in SR form. So instead of giving one tablet twice daily, I can give once daily. Suppose you will find not triptyline 10 mg with your pregabalin 75 mg SR. So once daily dosage instead of giving twice daily.
But the side effects are more pregabalin. That's why my question was that.
No,
pregabalin.
my day-to-day practice, I don't find that pregabalin has that much of
So
side
is
effect
it-
because I have tried.
But if you use combination with the methyl cobalamin, does it have that kind of a side effect with that one? With if you use the methyl cobalamin with the pregabalin?
No, methyl cobalamin will not do any more side effects. Why? Because methyl cobalamin, what does it do? It basically helps in myelination of neuron. Okay. And basically,
Combination.
combination, if you
Drowsiness and
methyl cobalamin, how does it help in myelination of neuron? That is also very simple. Because it gives the methyl donor, it gives a methyl group and it activates your methionine synthetase. Because of activation of methionine synthetase, it converts homocysteine by replacing with the methyl group, the sulfur group, it converts into methionine and it is subsequently converted into your lecithin. And lecithin is the major component of your myelin sheath. So because of methylcobalamin, there will be no such side. Thank you.
Thank you, sir. Thank you.
So that was a very fascinating lecture and incited a lot of discussion. Well, here I am tempted to ask Dr. Dev, if he takes private tuitions, for duffers like me, who don't understand any pharmacology. Well, thank you everyone for being here. I hand over to Dipin, I think, to conclude, and then dinner is awaiting us.
Thank you so much, sir. I think it's been a really enlightening sessions by both Dr. Aditya Khemka as well as Dr. Bijoy Dev, and really well moderated by Jolly sir. Really, it's been so nice. I would like to felicitate first Dr. Aditya Khemka. So I request Dr. Jolly sir to please give a memento.
Photograph, please.
Dr. Aditya.
Photograph.
I request Dr. Jolly sir to please give a memento to Dr. Bijoy Dev.
Pleasure to give a memento to my future guru.
I'll request my colleague Dubey sir to please present a memento to Dr. Jolly sir.
Sir,
Thank you very much. In fact, it's been such a lightning session. When we were talking about the pre-Kavalin, we also have T3 plus where we have PEA. So that's that's even better than pre-Kavalin, I would say. Sir has already highlighted about the Colashot C2 plus and our new Integrative code in chronic pain management. I'm definitely sure that you all will use it in your practice. So before I totally conclude the session, I will invite Mr. Kundan to please provide propose a vote of thanks. Yeah, please.
I am Kundan Rao, National Sales Manager from Innovacare Life Sciences. We would like to thank our respected living legend, Dr. Ashok Johri sir, for being the chief moderator for today's Ortho Connect CME. I would like to thank Dr. Aditya Khemka sir for presenting the topic on AI and robotics and how does it impact orthopedics. So thank you sir for your excellent presentation sir. I would like to thank Dr. Bijoy Dev sir for presenting topic on new advancement in chronic pain management. Thank you sir for enlightening and giving us bright knowledge today sir for chronic pain management. I would like to thank our respected directors, Mr. Dipin Verma sir, Mr. Vijay Dubey sir, for being a major guiding force for our today's Ortho Connect CME for exploring the orthopedics connect. I would like to thank all the PMT, our general manager sales, and our entire field managers and our field force for making today's CME a unique and new experience-oriented CME. So thank you very much. So now we have arranged a cocktail with dinner at Status Restaurant. It is very near to this dinner. So we will go. We will definitely take you.
Thank you.
Thank you very much.
Thank you, sir.
Thank you.